Hello, everyone, and welcome to December Beyond the Sea webinar. I'm Nancy Patterson. I'm one of the Outreach and Education Coordinators with the National Network of Libraries of Medicine Southeastern Atlantic region. And I'm delighted to welcome you today for a special two-part webinar. We just had, we're compelled with two really fantastic presenters, and everyone lately is so focused on the crisis before us of substance misuse and the ripple effects of problems in the communities. So what I'm going to do is introduce our first presenter, and then at 3 o'clock I will introduce our second presenter. So they're both fantastic, and I thank them both for being here today. Without further ado, our Part 1 presentation is Responding to the Crisis of Addiction in Our Communities. Our presenter is Nita Bryant. She's a behavioral and social sciences research librarian at the James Branch Cabell Library at Virginia Commonwealth University in Richmond. She holds a doctorate in sociology and also serves as a library liaison to the International Program in Addiction Studies, as well as the Humphrey H. Humphrey Fellowship Program in Substance Abuse Prevention, Treatment, and Policy. She's a member of SALIS. Do you say SALIS or SALIS, Nita?
SALIS.
SALIS. She's a member of SALIS, which is the Substance Abuse Librarians and Information Specialists Professional Association, an international association of individuals and organizations with special interests in the exchange and dissemination of alcohol, tobacco, and other drug information. I can tell you myself, as not a member, they've been fantastically responsive to my requests for information and help. So we're delighted to have you here today, Nita. Thank you so much, and I'll hand over the controls to you.
Okay, thank you very much. Now, getting to the PowerPoint.
Oh, hopefully you can see it.
Oh, there we go. All right,
oh, there we go. Oh, good, good.
Slightly hidden. Okay, well, good afternoon. I'm really glad to be here this afternoon because this is such a serious problem for everyone. So in this session, I'm going to be offering some suggestions for responding to the opioid crisis and other substance use disorders that plague our campuses and communities, and for many of us, our families. Doing so effectively means confronting widespread myths, misinformation, and misconceptions surrounding the use of substance use disorders, and responding in ways that are grounded in the science of addiction. So throughout the session, we'll explore the concept of harm reduction along with treatment and recovery approaches, and then consider the role that each of us can play as advocates, recovery allies, and information professionals. And in order to facilitate these efforts, I'll share a variety of resources and highlight specific events that provide opportunities to participate in campus, workplace, and community events throughout the year. Before moving on, I want to just make a quick note on the terms addiction and substance use disorders. The DSM chapter on substance-related and addictive disorders includes substance use disorders that are measured on a continuum from mild, moderate, or severe for each substance. The focus here is going to be on the severe end of the continuum, even though I may use those terms interchangeably. So, let me move down here, and I've lost my ability to, here we go. So, let me go back. There we go. These are 5 of many myths that surround substance use disorders, but the science of addiction is fortunately slowly eroding myths like these. Number 1, there is certainly nothing simple about addiction, and we know that abstinence-based approaches are only one of many pathways to the recovery. And any path that's taken really depends upon an individual's needs and the nature and the severity of their problem. Number 2, patients taking opioid medications for pain can become addicted even when the drugs are taken as prescribed. Unfortunately, this myth has had the effect of leading to confidence in prescribing, over-prescribing, and certainly a sharp increase in addiction and fatal overdoses. And despite recent changes in prescribing practices, the amount of opioids prescribed in 2015 remained approximately 3 times as high as it was in 1999. There is a great deal of regional variation, however. Myths number 3 and 4 are common misunderstandings. They suggest that individuals with substance use disorders lack willpower or moral principles, and we'll unpack that a little bit more later on. Number 5, when prescribed and monitored properly, medication-assisted treatments like methadone or buprenorphine and naltrexone for patients with opioid addiction have proved effective in facilitating not only functional recovery, but reducing the risk of overdose and infectious disease transmission. I keep trying to page down. There we go. So the next, let me get back. I've got to, pardon me. The next issue is the definition. And the American Society of Addiction Medicine generated a seismic shift in the way we think about addiction with the release of their new definition in 2011. It isn't just a social, moral, or criminal problem. Addiction is a brain disease whose behaviors manifest in these and many other areas of an individual's life. This doesn't minimize the very real problems and behaviors and criminal acts that are driven by addiction, but the disease is about brains, not drugs. And it's about the underlying neurology, not the outward action. And while the initial decision to take drugs is voluntary for most, we know that repeated use can lead to changes in brain circuits that interfere with the ability to resist intense urges, therefore the compulsive nature, despite the harmful consequences, which is really problematic. And these changes can persist long after detoxification. So relapsing is not only possible, but it's also likely. Still, choice does play an important role in getting help, and we'll come back to that later on. But where does the concept of harm reduction fit into all of this? While abstinence is, of course, the ultimate goal, some users simply don't yet see a problem, and they're not going to cease using. And in short, there is no motivation for doing so. So in the meantime, public health practitioners and advocacy groups like the Harm Reduction Coalition emphasize a variety of strategies that are grounded in pragmatism and in humanistic values with the goal of reducing the negative consequences associated with use. We know that medication-assisted therapies can decrease the number of fatal overdoses and facilitate recovery. We know that needle exchange programs reduce the transmission of diseases, and that naloxone reverses opioid overdoses and saves lives. But it's really important to note that harm reduction is not without its controversy, and not everyone embraces this concept. In fact, some contend that needle exchanges or naloxone enable or excuse poor choices. But nonetheless, these are often the first step toward contemplating change and seeking help, and we'll talk a little bit about that later as well. So the importance of raising public awareness about addiction as a chronic disease. This slide is pretty self-explanatory. It requires, like all other chronic diseases, long-term treatment of a variety of consequences. And as you can see here, the relapse or noncompliance rates are similar to other chronic diseases. But despite the widespread acknowledgement that addiction is similar to other chronic illnesses, it's still treated almost universally as an acute condition, like a broken bone. We do know a great deal about evidence-based treatment programs and the need for comprehensive coverage. So the needs, the educational needs, medical needs, vocational and family needs, all these needs need to be combined in a seamless, comprehensive treatment regimen. And so here is the problem-solution mismatch. The acute care model of screen, diagnose, treat, discharge is giving way, thankfully, to continuing care and recovery maintenance. And we know that medical and mental health treatment is only part of the equation. Substantial body of research demonstrates that peer-based support activities facilitate recovery. We know that peer mentors function as models for core recovery values like tolerance or acceptance or gratitude. And most importantly, they help others reconstruct a recovery-based personal and social identity. This is critical. And then finally, considering the risk of relapse, continuity of care and support is essential. So discrete, unlinked interventions are giving way to a continuum. Now, and the importance of advancing recovery management. I want to introduce you to Faces and Voices of Recovery. This is the nation's leading recovery addiction advocacy organization. It promotes public policies grounded in science, compassion, health, and human rights. And I hope that you'll take an opportunity to take a look at this later on. But a particular note is their focus on sharing recovery stories. This really is in stark contrast to the anonymity of AA movements. And they really work hard to bring recovery out of the shadows and into the open. And so in addition to sharing recovery stories, they also share the family experience of survival and reconciliation. And this can really serve as a powerful check on the stigma and the perceived hopelessness that we often associate with substance use and addiction disorders. And the model has really become, the group has really become a model for numerous international recovery advocacy movements. And I want to shift here to talk a little bit about collegiate recovery programs. I recently completed a Recovery Ally program on the VCU campus and was really impressed by the depth of the programs provided to the students and learned a great deal about their needs in the process. The recovery program began in 1977 at Brown University, but it has continued its growth, certainly reflecting the widespread availability of drugs and the fact that young adults are really the highest users of illicit drugs and prescription pain relievers. And so this just gives you another picture of why they remain such a high-risk group. And this comes from the National Survey on Drug Use and Health. These are data from 2015. So what does it mean to become a recovery ally? Well, first and foremost, it's learning much more about addiction. It also involves learning about post-acute withdrawal symptoms and what that means for student success. This was interesting to me because I did not realize that shortly after and even continuing on past the last period of usage, these symptoms can become really severe. They have effects on the ability to experience any kind of joy or pleasure. long-term or short-term memory issues. It makes it very difficult for students to function, and so a range of supports are available to students to help them work through this period. And the goal here and the motto is that education should never defer to addiction, that students have a right to receive their education while being supported in their recovery. This is really essential. And I'm always amazed at their resilience, at their meetings, at their ability to, they're humble, and their willingness to share their stories are really, really awe-inspiring. Another piece of this is learning about motivational interviewing, and that's really motivational interviewing gives you some vocabulary to engage with students with, and we'll come back to that in a few minutes. But it's also essential to know about the treatment resources and services that are available on campus. But if you're a recovery ally in your community, all of this applies as well. So another important consideration is that there are many, many paths to recovery, and the way that path is chosen depends upon not only the needs of the student, but the nature and severity of their problems. It is critical to listen and really support with encouraging language. We spent a good portion of our training learning to avoid stigmatizing language. So instead of addicts, these are students who have substance use disorders. Instead of clean or dirty, those types of things that we just don't even think about when we're talking to someone who has these problems really make a big difference in terms of how they're treated. And in fact, several years ago, a researcher at Boston University conducted a research study among people who were healthcare professionals who were attending several conferences, and they provided them with two different scenarios. The only thing that was different about the scenarios was the language, and what they found was that the language influenced whether or not these professionals were willing to refer someone to treatment or how they were going to treat them. So language matters in more ways than we often understand. So again, we're going to go back to the importance of language when we talk about the various stages of change. But for us here on campus, the goal is to really just provide a safe space to listen, non-judgmental, and to provide a warm handoff to the right person on campus. Now, it really is important to understand the stages of change in the recovery process, how they relate to treatment needs, and how they relate to the strategy of motivational interviewing. Again, motivational interviewing provides a vocabulary for engaging with individuals no matter where they are in this process. I don't know if you can see that the first stage is pre-contemplation, and these are the folks who really don't recognize that there's a problem. They haven't even contemplated that something might need to be changed. And so it's not that they don't want to see it, it's just where they are in the process of recovery. And the feedback loops that you see here are based on, naturally, the chronic and relapsing nature of addiction. So this gives you a way of thinking about how this process moves from contemplation to then preparation. And so the way you talk to a student at this stage is quite different. And at the next stage, you're providing mechanisms for action, resources for maintenance, and so forth. So this is really an important piece of the process. And later on, I'll show you how to access some of the information on motivational interviewing and stages of change. Another thing that you can do is share a cup of coffee. Students in recovery drink a lot of coffee, and I want to brag about our recovery community here because they've done a remarkable job with the recovery roast. This is small batch custom roasted coffee that was developed by our own students in recovery and a local roasting company in Richmond, Virginia. And I will say it's delicious. It's really good. But the coffee itself, I mean, it's important in many other ways as well. And so here is a picture of our students at a coffee tasting, like a wine tasting sort of. But this is how they learn about the history of coffee. They get real involved in the complexities of roasting, how that process occurs, and tasting and preparation. And then they have our students also have a bike, the coffee bike that they pedal throughout campus, and the goal is to just stand there with your bike, handing out coffee to folks who are going to stop and talk to you, and engaging them in some conversation, let them understand what this is all about, and sort of not only spreading the word that we have these resources for folks who are struggling, but also reducing the stigma and the misperceptions about what someone who has been using drugs really looks like. So it goes a long way in not only providing extra resources, but facilitating change in perceptions. So from the recovery program, the goal, from the Recovery Ally program, the goal, of course, is to share what you know and to confront the myths and the stigma that attached to addiction and recovery, and to share the diverse stories relating to substance use disorders. Again, our students, our RAMs in recovery, have have monthly meetings where they share their stories, and in many cases, faculty members will give their students their courses credit for coming to these and listening to the stories. This is a really powerful way of introducing the stories to people who may be unaware, or of stimulating people who have stories of their own to step forward and become a part of this community. And the goal is really highlighting the recovery. It's all about the recovery, not the addiction itself. And then, of course, the next issue is to certainly share your awareness and knowledge with others through workshops. And one of the suggestions that we were given is to take the naloxone training and pass it on. So I took one of the trainers sessions back in the early fall. So, and our next speaker will talk to you a little bit more about that. But the importance of knowing is really sharing. And then being informed. This is really important. I work a lot with, I have a guide that I support drug and alcohol resources on, and I am routinely contacted by people who want me to link to their site, and these 9 times out of 10, well, almost 10 times out of 10, these sites are from pseudo practitioners. They're just abysmal. The point is to get traffic directed to them. So it's important that you treat or that you vet every treatment provider, whether you have a friend who is looking for treatment, you yourself, or someone in your community or your workplace is seeking a treatment provider. You need to know that rehabilitation is a huge industry, and there are really many unscrupulous providers, and I will say it's often difficult to spot them. I've spent a lot of time going through web pages trying to figure out whether this is bogus or not. And unfortunately, they often present themselves with or link themselves to programs like SAMHSA or the National Institute on Drug Abuse. And they look very, very professional, but it's really, really problematic. So enough about that, but this is, and I have a link to this in the PowerPoint that I'm going to send to this particular brochure from Nita. It's important that the needs of each individual patient be taken into account, recognizing that needs change, that a short-term duration, depending upon the severity, is often not sufficient. And there's also needs to be an understanding about what's expected of the patient. So this is really a good, and there are many others as well, but this is a really good pamphlet that gives you an idea of what really has to, what questions you have to ask to be really safe and secure. So the next thing, of course, is to share resources. And this is a guide that I maintain. This was, I developed this about 5 years ago with input from the Hubert H. Humphrey Fellows at Virginia Commonwealth University. These are mid-career individuals from low-income countries who spend a year with us. And what I discovered was that when they go home, of course, they lose their library privileges and don't have access to a lot of the core content that they need. So this was the outgrowth of that. This is a guide that Nita links to, and everything in here is open access. It's been widely vetted, and I want to show you a couple of things that will be really helpful to you. Let me go to, this is the gray literature tab, and it provides easy access to treatment manuals, to research reports, webinars, CME credits, and a lot more without having to search through really very complex and disorganized websites. If you've ever gone to the CDC or to NIDA or to SAMHSA, these sites change regularly and it's very difficult to navigate them. So just with this simple motivational interviewing search, you can see that it turns up results from RAND, the CDC, and the ATTC networks, which are supported by NIDA, Addiction Technology Transfer Centers, you see, is what the acronym stands for. And let me go to the next. The Education and Training Guide tab has access to new resources. They're all located here on the left, and again, all of these are freely downloadable. And then access to tools from SAMHSA and NIDA and a whole range of other education and training resources. So, and the agencies tab also has a nice list of the core agencies that serve treatment providers and agencies. So that's one resource. And then I want to mention this particular Reading for Recovery research guide is a labor of love by a SALIS member, Judith Ward at Rutgers. And her aim was to connect those affected by addiction to really helpful and inspiring books. So this is an authoritative and easily accessible resource for bibliotherapy, for clinicians, for educators, and it's geared toward anyone interested in the use of guided reading for substance use problems. So I would encourage you to take a look at it. It's really a valuable supplement. This was just recently completed, and unfortunately, Rutgers University, this was the last work that Judith did as a member of their substance abuse library. It's ceased to exist. But anyway, do take a look at that. And then I want to take a look at the Salas collection. And again, this is Substance Abuse Librarians and Information Specialists. And in 2012, Salas members published an editorial in the Journal of Addiction, alerting the field to the fact that many of the alcohol and drug specialist libraries were being closed or downsized. Materials were being discarded, librarians were being dismissed, and since that time, many more libraries and databases have closed. So a key recommendation in the editorial was to create a digital archive to ensure that the literature of the addiction field was saved and made available to people throughout the world. So the Salas collection is the result of this, and all of the materials may be either downloaded or e-borrowed for up to 2 weeks, and all of this is free. And I do want to put in a plug here and ask you to please consider donating to Salas for the benefit of researchers and students, treatment providers, and policymakers and so forth. And the PowerPoint that I'm going to email to Nancy will have all of these links in them. Of course, gifts are tax deductible, but they've done a remarkable job of some crowdfunding, and this is a really crucial effort on their part. And again, this is another labor of love of this wonderful organization. And for anyone who is interested in professionally in the field of substance abuse, I would urge you to take a look at Salas and consider becoming a member. We have recently combined our meetings with the Association of Mental Health Librarians, and we have a meeting coming up in June in Berkeley at a fabulous venue, and it's a small but intimate but international group of people who are just totally committed to what they do. I'm really proud to be a member. Now, I want to move on to some events, and the goal here really is to participate, and this is coming up very soon, so I hope you'll take a close look at this. The National Drug and Alcohol Facts Week is held in January every year. This year it's January 22nd through the 28th, and this site has a wealth of information, activity ideas, and toolkits. You can order free materials, and one of the things that I wanted to call your attention to was the Drugs and Alcohol Chat Day. I think this will be the 11th annual chat. This is an online live chat held between Nita scientists and students from around the country. And students ask any questions that they most want the answers to. And fortunately, they have kept the chat day transcript, so you can take a look at or get an idea about the scope and types of questions by reviewing those transcripts. But this is a really popular NIDA event, and it does so much good in reaching students at that critical point in their lives. And we know that they have responded in many cases to some of the evidence that's been presented to them about the dangers of, say, binge drinking and the dangers of smoking, the dangers of things like methamphetamines. And so we can see in the survey data that the national survey, the Monitoring the Future study, shows trends, very clear trends in declines over time. And we attribute a lot of this to events like this that function to inform and shatter the myth. So that's and so this is in January, and then every year during the third week of May, SAMHSA holds its National Prevention Week. According to the National Survey on Drug Use in Health, adolescents and full-time college students most often use substances for the first time during June or July. So this is a very timely event. They also provide all sorts of planning toolkits and promotional materials. There are webinars. There's a wealth of information disseminated during this week, and it's really an important adjunct to all of the other efforts of people who are involved in the prevention and treatment and recovery related to substance use disorders. And National Recovery Month. This is the national observance that's held every September. So in the same way we celebrate health improvements made by those who are managing other chronic diseases like hypertension or diabetes or asthma, Recovery Month really celebrates the gains made by those in recovery. And so literally tens of thousands of prevention, treatment, and recovery programs participate in this event and share stories with their neighbors and friends and colleagues, really to increase awareness and further a much-needed understanding about the diseases of mental health and substance use disorders. So the messages here are clearly prevention works, treatment is effective, and people can and do recover. And again, the remarkable thing about this, when you contrast it to the many, many years that alcoholism and other types of addictions were shrouded in anonymity and secrecy, this is part of that enormous paradigm shift in bringing this out into the open and celebrating the fact that recovery is possible. And providing clear evidence to that effect. So, let's see, we're doing well on time. Okay, so I have time to open this up to any questions that you might have. I may not be able to answer them all, but I'll certainly give it a shot.
This is Nancy talking here. You can unmute your phones and speak, or you can type in the chat box. And while other people are thinking, Nita, while you were, I think that recovery roast, while you were talking about the Ramsden Recovery program, that's so fantastic. And it sounds fantastic. And I'm curious if is it meant to only stay ever with the students, which is great in and of itself, or has it ever included faculty or library staff or other people on campus?
No, it includes everyone. In fact, recovery communities in the city of Richmond love Recovery Roast. I mean, this has become a model for other recovery campuses. And so there's a real, this has generated so much interest. I'm glad you asked about that, Nancy, because people really have latched on to this concept, and it's just beautifully thought out and executed, and I can't say enough about Tom Bernard, who was responsible for this. But yes, thank you for asking that.
just think it makes so much sense, and that's fantastic that it includes everybody, because a student sees their professor and vice versa, and that does just demystify the entire thing.
Sure.
The other question I have, and please, anybody interrupt me if I'm talking. The other question I have that is just interesting for those of us that haven't worked closely with substance misuse and information related or resources is the shift of language from addiction, like an addict or someone who suffers from substance misuse disorder, or just talking about substance abuse, and that language. Can you talk some about the timeline of the change of language?
Well, yes, although I don't have the exact date. The the American Society of Addiction, ASAM, I can't remember the name. Anyway, the addiction physicians came out with a statement several years ago about language and its importance, and the International Society of Addiction journal editors have all followed suit, encouraging those who are writing for publication to consider the language that they use. And I doubt that we'll be able to change the language completely. Even at Salus, we were debating the importance of changing from substance abuse librarians. How do you do that after you've had this name for many, many years?
Right, that's right.
But I think it does just bring to the fore the importance of thinking about the nature of the terms and how they're laden with all sorts of implicit assumptions about the nature of the person. So instead of someone being clean, I'll admit it took me a while, but these are people in recovery. And so once you adopt that language, it makes a lot of difference. And the recovery identity is very important. And so, we're all encouraged to adopt that term because it makes so much more sense. That answer your question?
No, it's interesting to me, and especially with national initiatives now, or even regional and state ones, but a lot of states have identified the opioid crisis, in quotations, as a state of emergency in their state.
Yes.
And more of them, which I pay attention to my region, but I'm not sure that I'm in tune with the entire nation on it. But which has brought it all to the forefront, which is very, very good to have discussions like this and understanding, and have somebody like you explain things, and Shantae, who will be coming at 3. So we appreciate it so much. Is there anyone else who has a question for Nita?
And again, I have the PowerPoint with all of the links in it that I can send to you, Nancy. And so you said you had a Dropbox that they can access?
Yes, yeah, and if you send that to me, I'll throw that in the Dropbox before the end of the second presentation, so it'll be there.
Okay, great.
That works. Looks like perhaps we don't have any other questions, and what we'll do, I don't want to start Shantae early because we advertised as, or how do you feel, Shantae? I'm calling on you.
It's your call. It doesn't matter.
I think we'll wait till 3, since that's what we, okay, advertised as, because there may be people who are going to tune in at 3 to just catch 1 hour. So we'll take a little quiet time. People are welcome to leave and come back or stay in the room. I wish I could sing. I would serenade you all. But Nita, thank you so much for presenting for us today. And I think, and I hope everyone here will come for Shantae's part as well, because it's such an interesting span of information between our 2 presenters, and I think you'll love the whole picture that they paint, both of them, from their experience.
Yeah,
so
and
thank you so much.
Yeah, it's an important package. Thank you.
Yeah.
Thank you.
And you know what? I actually do have one other question for you personally. Yes. I might as well ask. Um, the digitization project that Salis has done sounds so fantastic, but are there, most associations have, subgroups and committees and things. Can you give an idea of the different committees that are part of Salis, or if that even exists? I know it's a small group.
Yes, and I don't know. I know some of the folks who are on we call it the DIGS project because it's too hard to say digitization.
Yes.
Anyway, there are a couple folks who are key resources in that area, and Andrea I can't remember Andrea's last name, that's all I ever call her, but I can send that information along to you. But I've also included the Salis website on the slide, so you can
fantastic. Yes.
to that website.
I can check there, and I put the URL in the chat box for anyone who wants to check out Salis as well.
Great, yes, okay.
All right, well, thank you so much again, Nita. Really, really appreciate you presenting, and we will have a little quiet time until 3 o'clock.
Okay, thank you, Nancy.
All right, thank you.
Bye-bye.
Bye-bye. I've forwarded Nita's slide with citations here in case anyone wants to take a look at those. That'll be our music while we wait. Hello, everyone. It's Nancy Patterson here with the National Network of Libraries of Medicine Southeastern Atlantic region. I say that 1,000 times. Not sure where that came from. But we're ready for part 2 of our webinar series today. I think you all were here originally, but for anyone that might have come in new, your phone is muted, but you can unmute at the end when Shantae takes questions. And there, at the end, we will have a URL for handouts today and for the webinar archive where this recording will be. So without further ado, let me introduce our presenter. Shantae Hunt is the Opioid Misuse Prevention Coordinator and Overdose Response Program Coordinator at the Howard County Health Department, Bureau of Behavioral Health in Columbia, Maryland. I talked about you earlier today, Shantae, and I said her title is, it sounds like a superhero. Shantae is a Baltimore native with a 25-year career in the substance abuse treatment field. After earning her bachelor's degree in rehabilitation services, she started out as an addictions counselor and later became a certified associate counselor specialized in alcohol and drug counseling. She went on to earn her master's degree in organizational management, and after years of work in abstinence-based programs, such as the 12-step program we're all familiar with, she spent 8 years in medication-assisted treatment programs, and both experiences shaped her thinking, which I will leave it to her to share with you. Thank you so much for joining us, Shantae. It's all yours.
Thank you so much. And before we start, I just definitely want to just give accolades to Nita, not that she needs them, but she did an awesome job with her presentation and defining addiction and harm reduction and all of the resources and events that she made us privy to. So I just wanted to thank her for that presentation. And before I actually get started, I just wanted to, start at the very beginning with this opioid epidemic and really just give you information and background on opioids. Even though many of us have heard the term, oftentimes there is a slight difference between an opiate and an opioid. And opioids are drugs that are synthetic, that are not from the natural substance that comes directly from the poppy plant, where opiates come directly from the poppy plant, from the opium that is produced, and we have then morphine and codeine. And these drugs generally started out growing in dry, warm climates in the southeast, in Mesopotamia, and in China. And today they are mainly in Colombia and in Mexico. And these drugs do an awesome job of managing our pain. That is basically what their purpose is for. In addition to that, they do suppress cough and treat opioid addiction as well. What I also want to just bring to your attention is, even though they help with these conditions, opioids have this feeling of euphoria that comes along with taking the drug, and oftentimes that can then lead people to addiction. Actually, morphine, which is actually named after Morpheus, the god of dreams, because these medicines tend to have an ability to kind of capture our minds and put us in a space of comfort that we want to achieve over and over again, which, as I stated earlier, can lead to addiction. These medicines last 3 to 24 hours in the body, and depending on what types they are, and we'll go into some of those very shortly. But the harm in these medicines, even though they do wonderful jobs for us medically, is that in excessive amounts, opioids can suppress a person's urge to breathe. And with that, of course, that will lead to the death and the epidemic that we are seeing today. These are common prescription opioids that many of us have taken if we've had any type of surgery, if we've had, earaches, backaches, arthritis. These are medicines that are prescribed quite often, which is oxycodone, hydrocodone, oxymorphone, and then hydromorphone. And again, many of them are semi-synthetic and made in a lab, but they still have the properties of the natural opioids, which help with our pain. Then there are other prescription opioids, which I mentioned, morphine originally. Morphine is 10 times more potent than opium, and it is actually used for severe pain relief. And then we have codeine on the other side, which is used for moderate pain or cough suppressant. And those are the more natural opioids. Now, at the bottom, you see methadone and buprenorphine. And these medications are actually pain relievers. They can be used as pain relievers, but they are more often used for opioid dependence. So what happens is they help the substance user to alleviate their withdrawal symptoms. So as a person is then stopping the use of an illegal substance, they would take methadone or buprenorphine in a treatment clinic under doctor supervision that would help to remove any joint pain, any nausea, any vomiting, any chills. And many people describe this as the flu times 10. And then the person is then able, once they're comfortable, to return to work, to return to school, to then go on to care for their families, and get back into life again. You know, many people are not able to do abstinence, which is just going cold turkey. That does not work for everyone. And, you know, those people with substance use disorder should have the freedom of choice to choose these two methods of treatment for themselves. But again, because of the stigma that comes with the disease of addiction, they are often shunned from making these options. Then we have your illegal opiates, heroin, of course, being one of the main ones. Is actually made from morphine. And these are all of the common street names for heroin. Back in 1874, actually the Bayer Company of Germany introduced heroin for medical use. They were not aware of the addictive potential of this medication. And by 1903, there were alarming rates of abuse of this drug. And by 1924, it was declared illegal by law. And as you see, there are different variations in the color of heroin. And more often, the darker the color, the more pure it is. If it's more white, that may indicate that the drug has been tainted by the drug supplier who wants to stretch their profit and therefore putting many contaminants in with the drug that oftentimes makes people just as sick as the drug itself. And here, this picture actually shows a lethal dose comparison. These are the drugs that we commonly hear of today: heroin, fentanyl, and then carfentanil. Fentanyl is a medication that is actually a very powerful opioid that is used for cancer patients or post-operative pain. And that drug can be actually 50 to 100 times more potent than morphine. And then you see carfentanil at the right side of the picture, which shows just a granule of this medication. And carfentanil actually is synthesized opioid. It is 10,000 times more powerful than morphine, and it is actually intended for large animal use. It is not intended for human consumption. However, recently this drug has infiltrated the drug supply as well and has caused many deaths across the nation. Fentanyl is the larger problem, more so than carfentanil. This drug has been coming over from China and from Mexico, and it's actually being pressed in look-alike drugs. And actually, as you see in the picture, granules can actually kill. And if we were to understand the epidemic and how we actually got where we are, you know, the amount of prescription opioids that are actually sold has quadrupled back from 1999 up to 2010. And there was heavy marketing of prescription opioids by pharmaceutical companies, and prescribers were actually told that there was not a risk of addiction. However, that soon became clear that that was not the case. And actually, the deaths mirrored the prescriptions. So therefore, deaths also quadrupled as prescriptions quadrupled. And prescription opioid prescribing and dispensing, it quadrupled even though there was no sight that there was an increase in reported pain by patients. And just let me give you a little scenario, because what tends to happen is people transition from prescription opioids over to the cheaper street versions. Let's say you have a person who is in pain, legitimate pain, they see their physician, the physician prescribes an opioid, that person then still has more pain or breakthrough pain, and they begin to take more of that medicine, and they run out ahead of time. And with opioids, the prescription can only be filled in an allotted amount of time. So what does that person do? They're out of medicine, but they're in pain. So they begin to turn to family, to friends, to see who has these medications that they can then get for their condition. And oftentimes they end up going to the street then to find their supply. What happens is one pill in street value can be $80, where one bag of heroin is only $10. So there's a cost factor involved, which then a person who had a legitimate prescription then has transitioned to become a user of heroin. And I don't know if any of you have seen the movie Chasing the Dragon, Life of an Opiate Addict. It is actually a movie put out by the FBI and the DEA, and it shows different vignettes of folks that are substance use disorder, and they are using opioids, and it shows how their lives unravel and how they have been, you know, great students from good homes, even a corporate executive, and the struggle it takes actually in order to recover. So if you all have not seen that movie, I highly suggest that you take a look at it. It is on YouTube, and it is 50 minutes long. In terms of opioid misuse, let's just take a look at that, because this is really getting off to a dangerous road as well. And people tend to take the medication in a manner other than what the dose that is prescribed to them. You know, if it says take one every 6 hours as needed, and then that person will take 2 pills or 3 pills. So not following the prescribed dosing, or at least contacting their prescriber to see if there are other alternatives for their pain. In addition to that, taking another person's prescription, even if it is for a legitimate medical complaint, usually prescriptions are set for that individual, and sometimes can be based on that person's health conditions, that person's weight. So we should never consume a prescription that is not our own, even if it is for the same symptoms. In addition, people misuse drugs because they take them in order to produce a feeling, not for the actual cause of what the medicine was made for. So again, we're talking about that euphoric effect that people are looking for, and which is oftentimes because they want to escape something that may have happened in their lives, you know, or it's their way to cope with a difficult time or a difficult situation, or if life isn't going as they would like. Oftentimes people will then turn to drugs in order to produce a euphoric effect for a temporary escape. And then, of course, the use of any illicit drug is considered opioid misuse. So misuse can then lead to both psychological and physical dependence, where the person is consumed with the thought of using over and over again and will use at any cost, even over a family. Just want to make it clear, when many of us hear of drug use, we have a tendency to begin to categorize people and point to certain populations of people that we feel fit this example. But you know, I just want to make it clear that there are no exemptions when it comes to drug use. There's no demographic that has been immune to the effects of drug abuse, and all humans are vulnerable and can be vulnerable just given a situation. You know, oftentimes in Narcotics Anonymous and Alcoholics Anonymous, you will hear people say never, because again, you just don't know what you would do given a certain situation that you may be placed in, despite your upbringing. But it is, you know, age is exempt, gender, race, religion, sexual preference, and of course socioeconomic status. And just want to make you aware that actually the percentage of women actually who are facing opiate addiction is truly on the rise. For so long, it's still mainly males, but I just want you to be aware that we as women, or me, we are not exempt. And also the DEA made a statement, I just want to make you all aware of, that there is no geographic space, rural or urban, that has avoided the harms of heroin. I know recently I read an article of a farmer, you know, and you just don't know the extent that the opioid epidemic has hit, but he actually has lost 2 of his 3 children to opiate overdose, and he even feared losing his farm because basically he has little help to even tend it. So, you know, this problem, it comes with a great magnitude and a heavy weight and a heavy burden for all of us and for all areas of life, you know, not thinking that my food supply may actually be affected by the opioid epidemic. And with that being said, just let's look briefly at some statistics that we have here. This here is from the Centers of Disease Control and Prevention, and it shows a steady increase over the last 17 years. And this is all overdoses of all drug classifications. And as you see, in 2016, there were over 64,000 deaths in the United States as a result of drug overdose. And then we have here our national overdose deaths from the National Institute on Drug Abuse. And as you see, again, you know, the females are slightly rising as the years progress, but here we have over 30,000 deaths by 2015. And actually these deaths are beginning to climb so that the numbers are becoming so staggering that they're more than car accidents, homicides, and even suicides. And if we were to look at our Maryland statistics here, we see that the drugs that are not opioid related, it has just been steady across the years. However, as we look at opioid related deaths, they continue to rise exponentially, with 2016 being 2,089 deaths. I know many of you may be aware, and if you are not, Governor Hogan declared a state of emergency here in Maryland, and he has required all jurisdictions to work with the Office of Emergency Management to form opioid intervention teams. And he even put some dollars to help with those initiatives and with those strategies. So I know here in Howard County, we meet about every month, every 2 months, to go over our plans and what we intend to do. One of the first things we're going to do is help with our grassroots hotline in order to help get that implemented and you know, beefed up so that it can continue to help those with substance abuse and mental health conditions. Let's discuss the precursors of this situation. You know, how does somebody get to the point of abusing opioids or even having a substance use disorder? And SAMHSA goes over risk factors and protective factors of substance use disorder. And these risk factors that we have are associated with a higher likelihood of substance abuse. So if we have any of these factors in our lives, then what happens is our tendency and our movement towards substances in general is greater. Whereas if we have protective factors, they are associated with a lower likelihood of substance misuse, and they reduce the negative impact. You know, sometimes we have control over these factors in our lives, and sometimes we don't. You know, you don't have control over the fact if you're a kid and you may have a chaotic home, or you have ineffective parenting, or a lack of parent-child attachment, all of those things being risk factors. But you may have some control over your failing in school, or being able to cope with situations, or even your peer affiliation. So our job is to help work with youngsters to help them to have additional protective factors so that they will negate any substance use. But let's take a look at the risk factors actually for prescription drug and heroin use. And the first one being a history of mental health disorders, because oftentimes people who use drugs, they tend to self-medicate their mental health symptoms. That is the main reason that they are using substances, is because they do not have access to a counselor or appropriate therapy or appropriate psychotropic medications, or don't want to disclose their condition because of the stigma of it, so then they will turn to illegal and illicit drugs in order to calm their mental health symptoms. In addition to that, the early onset of tobacco and other drug use, many kids often model, of course, their parents when it comes to this. You know, if you have a parent who smokes, if you have a parent who uses drugs and alcohol, then oftentimes the likelihood that the child will follow suit is almost imminent. So we need to be careful of what behaviors we're modeling in front of children. Also, there's a genetic predisposition to addiction. However, we have to know that those genes will not, let's say, be awakened if we don't actually put the substance in our bodies. So it's important to tell children not to use. I know that may be difficult for many of them who are curious. It's just a natural part of childhood. But if they don't use, then that genetic predisposition doesn't have an ability to take over. Then children with adverse childhood experiences. So these are children who have been physically abused or sexually, mentally abused, have experienced divorce and separation. These children often come from stressful or traumatic home events, and these things correlate with health problems actually throughout their lives. So there is also like an intergenerational transmission of adverse child experiences, meaning if your parents have experienced them, the likelihood that the child will experience them goes up as well. And then those experiencing high levels of pain, oftentimes, again, it causes people to misuse drugs overall because they are in pain, and as I said earlier, they take more than needed. And then end up turning to illicit drugs. Then there are protective factors, and this is what we all want to make sure that we are showing children in our community, and that is giving them a greater perception of substance abuse risk. They need to be educated on the issue. A lot of people feel as though, you know, if I don't tell my child about it, they won't become involved, or they don't need to know that right now. They're too young. But generally, we do need to begin to have conversations with our kids about just being cautious. And you know, we remember the Mr. Yuck stickers when we were coming up about you just didn't touch certain things. You just didn't engage in certain things. So we just need to make sure that children are aware of that. Then a community norm against substance abuse. So if they need to hear and see messages about not using, if they have a strong neighborhood attachment, maybe with their community center or maybe with their community group or even libraries, just hearing and seeing messages that are against it will then help children to be more protected against substance abuse. Receiving lower doses of prescription medication, or even asking for alternatives. I had an incident recently where I actually had a pain issue, and of course I was offered opiate medication, but being in the job that I am in and knowing and being aware of the dangers, I declined them after 3 days of use and asked for alternatives of exercise and therapy. And then having a stronger bond between parent and child, you know, giving clear rules of conduct that are actually enforced, and having parents that are involved, which can be a challenge because all homes are different. But we do need the support of parents and coaches and teachers, daycare providers, physicians. Everyone plays a part in creating these protective factors. And of course, the more protective factors a child has, the lower their propensity to actually use drugs overall. So I just wanted to give you an idea of what Howard County is doing with this effort. And we have the HC Drug Free, which is a nonprofit organization, and they help to promote safe medication storage and disposal. There are actually 4 disposal boxes around our county where residents can drop off prescription medication that is no longer needed at any time at the police stations around the county. In addition to that, there is a drug take-back day. DEA has a National Drug Take-Back Day, and we follow their schedule, which is usually twice per year, typically once in April and once in October. But it's just imperative that prescription medicines not sit in your medicine cabinet because that gives teens and friends, contractors, housekeepers, all easy access to your medicines, and you don't want that to happen. During our drug take-back days, even the last one we just had, we collected over 1,200 pounds of prescription medication. So these initiatives do help to raise awareness of proper storage and disposal, and again, helping to get these unneeded medications out of the home and out of harm's way. We are also in full swing of a media campaign. As you see on the left, one opioid overdose is too many. And we are encouraging people to be trained in naloxone to help save a life, as well as to get treatment referral and resources from the health department. And then as you see on the right, that is the actual naloxone spray, which can save a life. And we just need residents to know that, resources are available in their area. And on our website, we actually have a resource guide of all of the inpatient, outpatient treatments, the buprenorphine programs, medication-assisted programs. And they just need to be aware that this medicine, this life-saving medicine of naloxone or Narcan, as it's also known as, is available. And with that being said, the Overdose Response Program is actually a state program. It has a state curriculum that I teach from every month. And I do these trainings actually here at the Health Department and at the Wellness Center, which is over at the Howard County General Hospital. I also go out to organizations, community groups, anyone who will ask. And over the last few years, I've actually trained over 2,000 people in naloxone administration. And, just as people are trained in CPR, they need to know and even consider being trained in naloxone, because so often these overdoses are happening in stores that we go to, in restaurants, in gas stations, in hotels. And as a concerned citizen, we have the ability to save a life, and we should be trained. We want to recognize the signs of an overdose. And those signs quickly are just unconsciousness, unresponsiveness. The person is going to be gray and clammy to the touch. They may have shallow breathing or none at all. Their fingertips and lips may be blue, and they may have a loud snoring sound, which could potentially be their last breath. In addition to that, when you see these signs, you're going to try to stir the person to arouse them, and if they are unarousable, you will call 911 immediately, give naloxone, and then provide rescue breathing until help arrives. The prescription monitoring program is also another program that I try to oversee here in the county, and we're responsible for making physicians aware of the requirements of the law. And the law here in Maryland says that all prescribers, that means physicians, dentists, physician assistants, veterinarians, must register for the PDMP, and they were to do that by July 1 of this year. And then by July 1 of 2018, they are actually supposed to use the PDMP on a regular basis. So with this system, the prescribers can see before they prescribe an opioid medication or another controlled dangerous substance, if the patient actually has other prescriptions for controlled dangerous substances, and therefore they can then modify their prescription that they were going to provide or even deny a prescription altogether. So this reduces the abuses that patients can attempt to have with their prescriptions, and it also reduces doctor shopping, because sometimes patients will go to one side of town and get a prescription and then go to the other to see another doctor. So this system, the Prescription Drug Monitoring Program, helps to thwart all of that and keep patients safe. And let's talk about community action. And that is, what can the community do to help and assist? And basically it's becoming informed. So by identifying what drug problems are actually, in your area, becoming aware of the drugs of choice in your area. And there is a Maryland Public Opinion Survey, which is what that MPOS stands for. It is put out by the Behavioral Health Administration and the University of Maryland School of Pharmacy. And it goes over the ease of getting drugs from physicians or family members and friends, the ages a person started to use opioids, and it tracks that. In addition to the YRBS, which is the Youth Risk Behavior Survey, which is put out by the CDC, and that shows the prevalence of drug use among adolescents, and it shows any parental monitoring of their use. Then you would like to meet with community leaders who are involved in drug prevention, and I listed many of the agencies that we work with here in Howard County. We have our police who give us overdose data, both fatal and non-fatal overdoses, and we have peer recovery support specialists, which are people who are in recovery themselves, who then make contact with the families and those people who have survived an overdose to offer them resources. Then we have fire and rescue, which gives us overdose incidences that may be related to even all health complications. The health department, of course, we monitor the entire system of substance abuse in our area. So we have what's called a local addiction authority, and we make sure that there is enough treatment in our community, enough providers for those who need it. And we are now looking at ways to bring more providers and more treatment centers into our area. And then there are corrections. We here have a detention center that actually has a drug treatment program actually within the walls of the detention center. How can libraries be of value in preventing drug abuse? And just giving a place to actually house and distribute the educational resources. And I would say to make those in a prominent place. I know I went to a library recently, and there was like a little hallway with a little alcove where all of the resource material was, and maybe it was there for privacy's sake. However, it just seemed that many people would not, walk to that area of the library to even know that the resources were there and available. So you want to make a place to possibly house those things. Maybe have a teen corner, offer hotline numbers, make people aware of events that are coming up. Like every year we have an International Overdose Awareness Day. We also have Recovery Month. And then we have a resource guide from the health department. So again, having those materials available. Then having even a place to hold community forums. Recently I was asked to come to a library to give a presentation on opioids in general, just so that the community would be aware of the problem. And I actually did a mini showing of the Chasing the Dragon film. I just showed a few points from the movie just to allow them to see the struggle that a person actually goes through. It could be a place to hold educational workshop for specific age groups like teens or seniors, and then a safe place to talk. The library is typically a place of public information, so people may feel more comfortable talking in that venue. Then if you look at libraries' value in promoting recovery, just having items available on recovery issues and on addiction overall, on the disease of addiction, on the science of addiction and recovery. I just did a quick search of the libraries in the area here just to kind of see what resources they had available. And many of the materials seem to be fiction-based, not necessarily, research-based papers on the issue at hand. So just ensure that you have a robust listing of resources that are available on addiction or on all classes of drugs for that matter, on abstinence, on self-help groups, and even on the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, which actually describes addiction in detail. It talks about the obsession, using more than intended, the need for the effect, increased tolerance, and decrease in life activities. In addition to that, community groups value in preventing substance abuse and, the ability to just recognize people that are in danger. You look for changes in people's behavior, you look for lifestyle changes that come about. You don't want to berate someone, but offer a helping hand when you recognize that things may not be in order with them. Also, it's a good idea to follow on Facebook or Twitter your police department or your health department so that you can see what's actually happening in your community so that you can have a heightened awareness. When you identify families that are directly impacted, then you can offer support. You could actually possibly contact treatment providers and provide them with resources that may be available to their patients that would help them. And you would know the age ranges and the children that are impacted. So not that you want to profile anyone, but you definitely want to know the signs to look for. You are the first line of defense. You know what goes on in your neighborhoods. And, the new campaign that I've been hearing a lot recently is if you see something, say something. It's a new PSA that's actually been airing on radio stations. Then also there's educational presentations and awareness. So Nita actually has a booklet called Preventing Drug Abuse Among Children and Adolescents, and it's a research-based guide. And basically you want to see that whatever you decide to do for your community, does it really address the problem that you want to address? And I actually found an example in Wisconsin where they work with their health department, their attorney general, their medical society, the Chamber of Commerce, and they all came together to promote a campaign called A Dose of Reality, which is to prevent prescription misuse. You may actually have printed materials where you create newsletters or posters, flyers, and postcards. You may have to actually survey your community or even have a focus group to get a pulse on what the community issues are. There may be services that may be needed in your community that you may become aware of and can assist, and that is, do people need vocational services or child care or housing? And then there's always, of course, the media, where you have your TV, your radio, your newspaper. I know we've recently had a newspaper reporter who has been gracious enough to highlight us on several occasions here in our efforts that we're doing. But it all takes collaboration, working together to develop plans for prevention through coalition. So working with churches and recreation, parents, citizens, healthcare, social services, youth organizations, and even law enforcement to actually get the job done. How can the community be of value in promoting recovery? So it actually can give you a personal stake toward a safer community. So you aren't just talking about the problem, but being a part of the solution. Maybe volunteering to lead discussions, allowing others to use your hall or your conference room. You're promoting healthier communities. So when we think of those with substance use disorders, we think of them as outside of our groups that we have in the community, but they are probably secretly in our groups, just hiding. because of the stigma. So the information that you can offer will not only help your community at large, but it may help your group members as well. And, you know, it helps also to move us from a place of judgment of the actions of others to actually being open, an open agent of change. So we all are recovering from something that causes us pain. And, you know, when we're in recovery, you know, you try to develop healthy habits for a better lifestyle. So the more we lead people to recovery resources, the less likely they are going to be involved in negative and illegal activity, and thereby protecting our properties overall and our community. So we just need to let our residents know that recovery is possible. We need to encourage others, tell them not to give up and to keep at it. And how you can help also is there's a website in Maryland called Before It's Too Late that came from the governor's office. It's the state's effort to bring awareness to the epidemic. There's also the Maryland Crisis Hotline number, which is here. And usually it rings to your local jurisdiction, even though it's the same number for the entire state. We ask people to, again, get more information on the Naloxone, the reversal medication for opioid overdose. And you can find more information on that in the locations of the trainings in your jurisdiction at the link below from the Behavioral Health Administration. And as always, if you need help, call 911. But we also want you to remain informed. Many areas have what's called a local health improvement coalition. We have one here where we have many organizations and businesses in the community who come together to improve health in various areas, whether that be suicide or whether that be healthy weight or whether that be substance abuse. There's also organizations called recovery-oriented systems of care in many states, and that again comes down from the federal government. And these are, again, organizations that come together to formulate strategies and put plans in place in their local areas to promote recovery. There are other jurisdictions that I know of that are doing wonderful things, like having recovery over dinner, where they have speakers come in and offer the community dinner. People talk about their story of recovery and how they made it through. And then there are local behavioral health coalitions as well. Here we have our alcohol and drug abuse board, and people from the public are welcome to come and hear what we're doing. And I always ask people to, again, become a follower of your local government agencies on social media through Facebook and Twitter to stay informed. And with that, I'll ask if there are any questions. Someone said, repeat the name of the movie. It is Facing the Dragon, Life of an Opiate Addict, and it's put out by the FDA and the FBI, excuse me, and the DEA.
I went ahead and pasted. This is Nancy. I pasted the link there, and I realized I made a little error in my second one, that it's not just substances; it's specifically opioids. The second documentary.
Yeah.
Yeah. So for anybody who's interested.
One thing I just want to make you aware of is that there are two versions of the Chasing the Dragon film. If you are averse to profanity, there is an edited version as well.
Oh, good to know. Thank you. But it sounds like gritty truth, you know?
Yes, it is.
Yeah. So while other people are thinking, and if you have a question, feel free to unmute your phone and ask, or you can type it in the chat box. But I have a question for you, Shantae, in terms of, I have a few questions, actually. You have increased the number of teachings threefold, I think, since you began doing what you do in Howard County, so thank you for that. I live there. But how do you measure your success? Like, information's power. You've got a group of librarians here, and we all agree, of course. But how do you have an idea of your impact? Because obviously, if you prevent someone, you have no idea. You know, that's hard to gauge. So how do you evaluate what you do?
It is really difficult to gauge because as we're putting out so many initiatives, we still see numbers going up. And that is oftentimes disheartening because you're trying to get the message out. We have banners at the mall, you know, we have banners on buses, and we're just trying to make the community aware that this is here in our county. And it's very difficult to gauge what's happening because truthfully in an epidemic, it may take 5 to 10 years to see a change. Because what you're looking at is the younger folk are, you know, there are people that are already in the system that are using drugs, but then there are young people that we're trying to prevent from moving into it and trying to get the message so that they will not fall prey to these things.
Right.
So it's very difficult to really see the overall impact. When we see the numbers staying steady, that makes us feel a little more comfortable than if they're on the rise. And we do have some months where they stay pretty low or average, but then we have others that just make us say we have so much more work to do.
Yeah. We do outreach for boosting people's health literacy for general health topics, but it's always hard because information's good, you know, but how do you tell if they ever use it, you know? So it's the same kind of thing.
It is.
I see that you have a comment from Diana that you've got another gig proposed. So,
I do?
Yes, the Office of Minority Health Resource Center in Maryland wants to arrange a webinar with you. So
wonderful.
Shantae's information is right there on the screen, so I hope that can get you two connected.
Yes.
Oh, I put it on it's on the last one as well.
Okay. Thank you, Diana.
Yeah, that's great. Now, your presentation was fantastic, and one of the things that it highlights, too, is that this, you know, you and Nita both hit on this terrible thing we do to the problem in terms of blaming the person who is, we blame the person, where it seems to me that Big Pharma sure has a lot of responsibility. And I know that it's maybe a little outside your purview, but do you know if there have been ramifications or anything in regulations that's helping on that end?
I think the only thing that's helping on that end is that, you know, the federal government has passed so many opiate prescribing guidelines that are coming down to all of the prescribers. Because, you know, back in the early 2000s, it was just a push to say if people are in pain, you prescribe opioids. You know, that's what you do. Where now that we have the epidemic, the tide has turned. And actually the Surgeon General has a booklet online about turning the tide. And it's where prescribers can actually log on and receive this information and kind of pledge that they're going to help to turn the tide of this epidemic, so that they're going to, you know, do their best to stay within the new prescribing guidelines. But in terms of, you know, any sanctions or anything involved, I don't see that anywhere in any regulations or laws at the moment. But at least they want physicians and all prescribers to be aware of what the expectation is.
Yeah, that's fantastic, and I wasn't familiar with that resource, so I will definitely look at that. You've given us wonderful resources. You have lots of thank yous in the box.
Thank you. I appreciate the time, and I thank you so much, Nancy, for inviting me. I thank you.
Oh, thank you, and I'm so delighted that you could come, and it's really fantastic information. I'm not surprised you got another gig. If no one else has a question, I just want to tell you a couple of things. Let me just make sure if there are questions or comments. All right, speak up if you like, but I'm going to continue just to tell you. The slides, yes, the next slide that I forward to will have a link for you where you can get a copy of the slides. That was a question in the chat box. I do want to tell you all that in February 1st from 2 to 3, we're having another Beyond the Sea webinar. The speaker is Ione Damasco from the University of Dayton, and her twist on diversity and librarianship, which we see that topic a lot and it's important and wonderful, but her twist sounds really intriguing to me, which is what we don't talk about when we talk about diversity and librarianship. So I think that'll be a really interesting Beyond the Sea. Hope you'll join us for that one. And here's the contact information for both Nita and Shantae. The MLA-CE certificate is there at the bottom left for anybody who wants to get the CE for that. You do a little survey and you can print your certificate. The webinar recording will be at that URL on the lower right within a week, week and a half. And the PowerPoint download is at the very bottom in the blue. So you should be able to access that from Dropbox. So thank you all again for coming. Please spread the word. People are welcome to watch the recording. And Shantae, I can't thank you enough. I have a feeling I'm going to be bugging you again.
No problem at all.
Be warned.
Thank you.
Thank you so much, and thank you all for coming. Happy holidays to everyone.
You too.
Bye-bye.
Bye-bye.